right away
Yeah,
after. No,
yeah.
yeah, but it's because all over it's been like that. Presentations has been like that.
But I don't.
But we can do it like that.
Okay.
And of course we will take time from the end. Oh, that's the name of his organization.
So you want us to sit down there?
So it's,
Here, here's a description is quite long.
yeah. Okay. Good afternoon, everybody. We would like to start this session. My name is Sigurður Ólafsson. I'm from Reykjavík, Iceland. And the title of this session is What's Next in Efforts to Achieve and Maintain HCV Elimination Among People Who Inject Drugs. We will have a question and discussion session after all the talks. And once the speakers have finished their talk, I would like them to join us here in the podium. Now, the first speaker is Sonja Shelton, and Sonja joined PWID in January 2017 and is currently Deputy Director of Operational and Implementation Research following a 4-year role leading PWID's hepatitis work. She has over 15 years of experience in leading programs and implementation science studies, bringing together communities and researchers. Sonja, please.
Thank you. I'd like to thank the organizers for inviting me to speak, and all of you all for giving me a piece of your time. So I will be speaking on the latest developments on rapid tests for HCV. I'm from the organization PWID, the Foundation for Innovative New Diagnostics, and we're an international nonprofit that focuses on development and scale-up of high-quality, affordable diagnostics in the Global South. And so my talk is a little bit more Global South focused, but I hope that it will resonate also with peers from the Global North. So I know I'm preaching to the choir here, but viral hepatitis, what do we need to do? We need to find the missing millions, we need to link them to care, and we need to do it in a cost-effective manner. This is particularly important because the global funding for hepatitis is not in the same space that the global funding for other major issues such as HIV, TB, and malaria, right? There's no global funding body that funds hepatitis work in that same way. Although, with a new global fund call, they now have made it allowable to fund hepatitis C testing and treatment for all people, regardless of if they were living with HIV or not. So any of you out there that's on the CCMs putting together global fund calls, that can be, you can put it into your proposals. So that's really an excellent news. But without that, with domestic funding and a lot of priorities on national budgets, they have to make hard decisions. And so ensuring that we can provide hepatitis C care, particularly to people who inject drugs and other populations that need particular attention and really thoughtful care about the care delivery models, we need to try and do this in as cost-effective a way as possible. So I always start off this version of the presentation with the WHO testing guidelines. This is because I think WHO has a very nice simplified testing guideline that may be being picked up a little bit more in many more global South countries than in the global North. So it starts with a single test for either ELISA or a rapid diagnostic test. So this is for antibody. Then if antibody positive, prompt or reflex HCV RNA or core antigen testing for confirmation of viremia. Then assessing and triage, staging liver disease using non-invasive technologies, so APRI, FIB4, FibroScan. I think this is important because I was talking to a colleague from Eastern Europe, and in their context, they're still doing liver biopsies, which is not needed. You don't need to do that. Treat all with pangenotypics, and then one test of cure for sustained viral response. Now, this is important because there are no recommended RNA tests while on treatment. There is no recommended RNA test for end of treatment, right? So it's just 4 tests, hopefully an RDT, confirmation of viremia, liver staging, and then test of cure. Now, of course, there are considerations on this, particularly when we are thinking about people who inject drugs. So the first one is some countries in the global north are now trying to consider to just drop the antibody test and go straight to RNA. This is because of the loss to follow-up that we see when someone gets an antibody test and then getting that confirmation of viremia. However, the work that Karen Lacombe has done in West Africa and the work that Jason Gribley's group is doing show that you need pretty high prevalence to make going direct to RNA to be cost effective. In Karen Lacombe's work, it's 30 to 60%, and we look forward to seeing the other analysis that are coming out. Right, so by just going right to RNA and not doing the antibody, it's going to be more expensive. The work that Yvonne Hutton and Margaret Hellard have put out about costing the hepatitis response, the screening is going to be the most expensive part, right? So figuring out how to do that in a way that's cost effective, but in a way that is patient-centric, so you don't lose people between those 2 steps is critical. So they don't recommend genotyping, right? But would we want to consider doing a DBS, a dried blood spot for genotyping when somebody is confirmed to have viremia? So you can keep this down. So in case they do not achieve SVR, you can do another DBS and see, okay, is this treatment failure or is this reinfection? And then the good old liver staging. Now, WHO recommends that you do liver staging before treatment initiation. There can be a discussion about if that's needed or not. But the challenge here to same-day test and treat, which is what we all want to get to if it makes sense for the recipients of care, is the liver staging is not point of care, right? If you're lucky enough to have a FibroScan, that could be, but it's expensive to calibrate the probes. It's not super mobile. And APRI and FIB4 right now are all biochem. They have to be done in a lab. Treating all with pangenotypics, and then the SVR, do we want to consider a DBS? So the first part of the step, the serological testing. We know that we have several hepatitis C rapid diagnostic tests that are WHO PQ'd. So here are the ones that are PQ'd. This matters for a lot of countries because in order to be able to procure things through global fund funding, it's got to be WHO PQ'd or on the ERPD list. Just to say that the list price is fairly attainable, right? Usually less than $3, unless it's OraSure. So that's one thing. Then there's the combo rapid diagnostic tests. So these are a lateral flow test that on one sample you can test for multiple different diseases. But the challenge here is that these tests have not been independently validated, right? So we don't know their performance. We know the performance that the manufacturer is telling us, but we don't know the individual performance from an independent assessment. We also don't know what use cases these make the most sense for, right? So what are our specific groups of people that we're trying to reach that these combinations of hepatitis B, hepatitis C, and HIV, some also have syphilis, what makes sense? So we need to do operational research to figure this out. We also need to understand how people feel about taking all these tests at once and potentially getting a lot of information about their health status at once. How are they going to manage that? What are the supportive mechanisms we need to put in place to allow those messages to help people move towards action? And we need to look at the cost effectiveness of this. So apologies for those of you who are in my other talk. I'm going to rehash some of it. But WHO in July of 2021 has recently issued the first ever recommendation on hepatitis C self-testing. So this is antibody testing. And WHO's recommendation is that it should be offered as an additional testing approach. It was a strong recommendation based on moderate quality evidence. So here are some links to the resources. The hepatitis C self-test is not on the market yet, though. There are a few manufacturers that are going through the stringent regulatory authority process now, and there are some other manufacturers that have expressed interest in prototypes, and we'll see how they develop. I mean, COVID, as with all things in all of our lives, has disrupted a lot, and it's really taken the manufacturer's attention away from everything else except for COVID. And now they're starting to think about other non-COVID things. So can we capitalize this and get them to move forward to bring more self-tests to market? So you might be wondering about self-testing. Before COVID, I think a lot of people, particularly laboratory people, medical personnel, were a little bit worried about self-testing, a little bit worried about losing control over the process and the quality and the interpretation of results. And now we've shown by HIV self-testing, which has been going on for 20 plus years, that it works. People can do it, people can interpret the results, and they can get linked to care if it's provided in that supportive kind of envelope. So we had to do the same thing with hepatitis C, just to prove that people can do it. And we had to do the same thing with COVID self-testing to prove they can do it. And spoiler alert, they can. But we've done a series of feasibility and acceptability studies in a large number of countries with different kind of population groups. And what we have found is that people can do it. In the case where we provided an in-person demonstration, so this was the participant was provided a demonstration, how to use the self-test, and was taken to a place where they could do the self-test. They were observed with a standardized checklist to see did they do all the steps correct. And then they compared the results of the self-test to the results of a professionally provided rapid diagnostic test of the same manufacturer brand. And what we found is that the majority of participants can interpret the result correctly, and there is a high agreement with professional use test. And this population was important because it was a low literacy population. So we wanted to see how that could work for people who might have lower literacy rates. Then we looked at unassisted self-testing. So in this model, we just gave the participants the instructions for use and said, all right, figure it out. And then we observed them with the standardized checklist and then did the same testing process with the professional use version. And we also saw that people are able to perform the test, interpret the results correctly, and have a high agreement. However, I would like to highlight that in Vietnam, among people who inject drugs, we do see a lower interpretation of results and agreements. And so this just highlights, as I had said in my other talk about the uptake and the impact, this highlights the need to consider the appropriate supportive materials to go along with the self-testing package. So switching gears completely, can we use a serological test for confirmation of viremia? So Jordan Feld's group has done this interesting study which looked at when you are using the OraSure test with plasma or blood, not oral fluid, what happens if you read it at 5 minutes instead of the longer time you're supposed to wait? Well, at 5 minutes, they found a positive predictive value and a negative predictive value of 100% for antibody, which is great. And then they also looked at the positive predictive value for viremia. And they saw that the positive predictive value was 62%. So it's good, but that means that there's, almost 40% that are coming, the band is coming at 5 minutes, but they don't have active viremia. And so the question is this enough to be able to initiate people on treatment right away? Margaret Hellard's group is doing some interesting work on this, and she's got really great thoughts. So I suggest to you to reach out to her to think about the pros and cons of potentially overtreatment versus losing people along that care cascade. So to talk about RNA. So COVID has provided us an opportunity in that there's been an explosion of near and true point of care platforms using molecular, right? So how can we consider this, and can we consider this to be useful for hepatitis? These are the available near point of care assays available on the global market. We know the Cepheid, the finger stick, and the plasma. There's also the gene drive and the TrueNat. However, right, the technology is only as good as the system it is placed in. So I think Jason said it well before, you know, we can't just go around putting molecular machines everywhere. That's not going to work. So we need to think about, are we going to put this in a place that's actually going to have patient impact? And the most critical thing for this is simplifying the patient journey. So I will just give you one example, which is in the country of Georgia. Before we did this work, they were seeing over 60% loss to follow-up among people who inject drugs who were getting an antibody test to get that confirmation of viremia. So what we did was we placed a gene expert in 4 harm reduction sites, and then in 2 harm reduction sites, we implemented a system where after an antibody test, if the result was positive, then that participant immediately had a blood draw for a confirmation, and that was sent to the centralized lab. So the participant did not have to move, versus the standard of care where the participant had to get, you know, tested at the harm reduction site for antibody and then had to go to another clinic for the confirmation. And what we saw was that the completion of viremia test between the expert and the clinical reflex was very high, 100% in the expert arm and 99.8. That 99.8 is because of a participant that had difficult venous access, and so we unfortunately were not able to just get the blood draw done. You'll also see the third bar is that the starting treatment also, there was no statistically significant difference between those diagnostic modalities and initiating on treatment. So what potentials can we take away from COVID? We know that over 142 platforms are in the landscape. This is probably more now because it's an ever-changing number. And we know that 75 new molecular diagnostic point of care platforms were launched post-COVID. 16 of those are true point of care. So when we say that, we're not talking about the Cepheids or the MolBios. We're talking about something that you really can bring along and don't have to lug a battery and an air conditioner and all of these things. And 2, excitingly, are instrument-free. However, 45% of these platforms are based on isothermal amplification, right? So LAMP. And so this has some considerations we need to think about because there is going to be reductions in sensitivity and in the lower limit of detection using isothermal compared to RT-PCR. So some examples of near point of care in late stage development. So these are the ones that are equivalent to like being able to use in level 2. You still need power, you still need temperature control. But excitingly, while they are currently in development for COVID, they are hoping to consider other test menus, which do include hepatitis. And then we've got some true point of care. So here's the VISP and the Acela. These are available in the United States. The VISP does require electricity, and they are expensive, comparatively speaking. And the ability to reduce those prices is probably going to be limited because it is complex technology put in a very small box. Now, the COVID for the VISP and the Acela is a respiratory sample, and for the sexual health panel is a vaginal sample. Why is this important? It's because for hepatitis, we need it to be something else. We need it to be a blood sample, right? And ideally, a capillary blood sample. And so changing the sample type and the analyte in these platforms requires a lot of work. It's not going to be done tomorrow, and there are some cases where there might be technological challenges that we're not able to overcome. So it brought many new point of care, all these great things, but there are special circumstances. it was a pandemic, I think we remember that, there was a huge amount of money put into this, right? And levels that will not be put into hepatitis. And there was also a significant perception of a market by these manufacturers. So they were keen to go into this. For hepatitis, that may not necessarily be the case. And we also were able to do emergency use authorization. So the regulatory processes were much, much quicker than normal, right? Than FDA, than WHO, CE. So that's why we're able to get things so quick. That's not going to happen again until the next one comes. Do these innovations translate to hepatitis opportunities? They could, right? So these true point-of-care molecular platforms have been demonstrated and implemented. Companies are looking to pivot to non-COVID, but these platforms only have COVID experience, and respiratory sample preps have an entirely different sample prep than whole blood, right? So the pre-analytic stage is different, and to overcome the technological challenges that we see with isothermal, we don't want to have a true point-of-care platform and then use serum or plasma, right? Because how are you going to get that? If you have a true point-of-care, you don't want to have to go to a centrifuge, right? So we want to figure out how we can get to that whole blood stage. Hepatitis C testing is more similar to HIV platform testing in terms of technology and what you got to do. And then there is the core antigen RDT, right? So this is something that is currently in development, and we'll see if it's able to come to fruition. It does need additional sample prep, and there are questions around sensitivity, right? So with core antigen, we know that the sensitivity is going to be a bit different than with RNA. Just to highlight the challenges with sample types. There's all different sample types we can use for a lot of different things, and we want to get to the blood for hepatitis C. A last thing just to think about, I had actually taken out my dried blood spot slides because I thought I was going to go over time. But a consideration for point of care as well as for DBS is the lower limit of detection for SVR. So we know that the lower limit of detection for confirmation is 1,000 IU per ml. Is that going to be enough for SVR? And well, maybe, but if we set that lower limit of detection at 1,000 IUs per ml, we are going to miss about 10% of people who have not sustained viremia, right? So we're going to think that they have sustained viremia, and they haven't. This is from a multi-country global meta-analysis. So the main takeaways are hepatitis C self-testing is an opportunity to reach those who would not be reached by professional use testing. People can do it. We should trust them. Combination RDTs, we need to do more work to understand the performance and the optimal use cases. True and near point of care, we've got lots of opportunities, but we need to be realistic about our expectations. And the lower limit of detection for SVR, 1,000 IUs per ml, would miss approximately 10% of the people who actually did not achieve SVR. Thank you very much.
Thank you very much for your excellent contribution.
It's my pleasure now to introduce our second speaker, Professor Graham Foster, which will be joining us virtually. Well, he is already there. And he's a clinical hepatologist with a long-standing interest in the management of health-related complications of addiction, and clinical head for the INHSU HCV elimination program. And if I may add, he's also a very engaging and powerful speaker, so I'm very happy that he's in this session with us. Please.
Thank you very much indeed, Madam Chairman. Thank you for inviting me, and I'm very sorry that I can't be with you in person. Unfortunately, I tested positive for COVID the other day, and I thought it was unkind to share. I'm going to talk a little bit about how we scale up hepatitis C treatment, and these are my disclosures. And really the summary of my talk is just get cracking, let's get on with it. But I want to start by making it very clear that there are some huge issues, and I think we've all got very excited about the opportunities for rapid point-of-care testing, rapid access to treatment, rapid take-up amongst people who inject drugs. And I think that this group has made a huge contribution to accessing treatment for people who've previously been overtly discriminated against. And I think that's rather blinded us to some of the issues and the problems that we have to face. So let me start with the issues. This is my give-a-damnometer. This is how I think about all of my patients, not just people with hepatitis C, but the time it takes an individual to engage in treatment is very much determined by how excited they are and how worried they are by that particular health condition. And every single member of this audience has their own give-a-damnometer. I'd like to bet that nobody in this room is entirely up to date with all of their blood pressure measurements, their dental checkups, their cervical screening, their bowel cancer screening, their PSA, etc., etc. We all have a threshold where we decide that this is important enough for us to access healthcare. And of course, if we want to improve access to healthcare, then we have to make more effort to get people treated, particularly for those people who have other priorities. So I think about people with hepatitis C in three broad groups. The first are people who are really worried, really anxious about their infection, and they'll come along to the clinic. You don't need to do anything for people who are anxious about hepatitis C. They will find you, they will come to your clinic, and they will take the medication. Then there are people who are a little bit anxious, a little bit worried, and if you make treatment available in outreach services, and we've heard a great deal about that over the last 24 hours, those people can be persuaded to take therapy. What we haven't addressed, and what I think we are now starting to get to, are what I call the GOKs, the God only knows. How do we get to people who don't see hepatitis C as their priority, who have other pressing healthcare needs? And that, of course, is the group that we're going to have to find if we're going to eliminate. And if we look back over the presentations of most of today and yesterday, all of the initiatives that I've seen so far all have a little rump of patients, around 20 to 30%, who have not accessed treatment, no matter how simple we make it. And I think we need to be honest with ourselves and say there are a group of people out there who are simply not going to take hepatitis C treatment. But of course, attitudes change. And for me, one of the important messages is that people change depending on circumstances. A very good friend of mine has recently had coronary artery bypass surgery. He'd taken no notice whatsoever of his chest pains. As he said, I thought everyone got a bit of chest pain when they went walking. Well, maybe not. That's led to 3 of my close friends attending casualty with chest pain and having a cardiac workup. None of them have significant cardiac problems, but they'd all ignored those little niggles until something happened that made them give a damn and made them get anxious. So our job is to recognise that the treatment services we provide have got to be there for a very, very long time, so that as people's attitudes change, they have an opportunity to access care. So that's the theory. Let me show you some of real-world practice. This is Doug MacDonald from the Royal Free Hospital in North Central London. It's a paper due to be published very shortly. And what he's done is looked at access to treatment by time and by the number of contacts with healthcare professionals. Now, Doug has an all-singing, all-dancing service. He has a bus with point-of-care testing, instant access to treatment, instant handing out of medication. He has outreach nurses, instant access to therapy and addiction services. But you can see some of his patients are taking 40 or 50 contacts with healthcare workers and over 3 years to access treatment for hepatitis C. You can see on the left the time to therapy by compliance factors. For people who are engaged, time to treatment is very short, but once you have 1 or 2 compliance factors, problems other than hepatitis C, your access to care is greatly reduced. No matter how simple you make it, there are a group of people who do not want treatment. And in a free society, they're perfectly entitled to tell you they don't want treatment. So hepatitis C is for many people not top of the priority list. And that, of course, is not just people who inject drugs. I have patients who have left drug use many years ago and they still don't want to take hepatitis C therapies. I have patients with haemophilia who are anxious, don't trust the medical profession, who won't take antiviral therapy. And for those patients, we may need to think about some different strategies. So let me think about some possible solutions, and in particular, solutions focused on people who actively inject drugs. The first trick is a trick that I think many groups are now starting to adopt, which is to use peers, people with lived experience of hepatitis C. And one of the characteristics of peers is that they engage with patients in different ways than healthcare professionals. And we have a very active group of peers in England. They're trained by the Hepatitis C Trust. They've all got lived experience of hepatitis C, and they all engage with our patients and our clients in ways that you and I can't possibly do. And here's the outcome of introducing peers to our treatment services. In England, we divide our hepatitis C program into operational delivery networks, and each of these networks introduce peers at different times. And by comparing networks with and without peers, we were able to show that there's a 12% increase in the number of people who start treatment in networks with peers. So there's absolutely no doubt that introducing peers into your treatment program will significantly increase the number of people who start therapy. You saw this data a little while ago from Pantelis and his crew looking at treatment intensity and showing that if you increase the intensity of treatment, you make more treatment available in more places. And what Pantelis and his colleagues have been able to show that if you do that, increasing the availability and access to treatment on a global level, in Scotland they've been able to show dramatic reductions in hepatitis C prevalence. We don't yet have comparable data for England, where the sample size is too small to comment, but I strongly suspect we'll see exactly the same. So if we're going to treat people whose interest in hepatitis C is perhaps less than our own, we need a diversity of treatment providers, we need easy access to therapy, and we need peers. I want to caution by just reminding you that we do need high quality data to evidence the approaches that we use. Because intuitively, all of us would have thought that directly observed therapy would have been a very good way of improving treatment access. This is a study by John Dillon's team, randomizing patients to directly observed therapy versus fortnightly provision of Hep C medication with or without psychiatric intervention. And again, the study's been published, and what it shows is that across the board, directly observed therapy has no impact on access to treatment, on SVR. So whereas I think many of us were convinced that directly observed therapy was going to be a prerequisite for effective therapy, the data, the randomized control trial, shows in fact that if anything, there's a slight reduction in SVRs in those on DOT compared to the other forms of treatment, although this wasn't statistically significant. So we do need to be careful that our own personal prejudices don't bias the way we deliver therapy. One of the key treatment access points for me is to catch people while they're engaged in services and when you can. And we've had in England a very active program of testing and treating in prisons. We send in a team, it's a team of healthcare workers, a team of peers. We offer testing and immediate access to treatment to everyone in the prison. And as you can see here, we've managed to test and treat 30% of the prisons. We've nearly completed testing and treatment in all of the prison estate for female prisoners, and we're now moving on in accessing all of the male prisons. It requires a lot of man and people power. Here you can see that for these interventions going into prisons, we need probably 10 people over a period of 3 to 4 days to deliver this intensive program. But the outcome from it, as you can see here, is that 90% of prisoners get tested for hepatitis C. Of those who are infected, interestingly, only 17% of the antibody positives are viremic, which perhaps indicates that in England we're getting quite a long way down the hepatitis C elimination cascade. And of those, 93% were able to start therapy. So catching people while they're engaged and available for treatment, offering them treatment at a time when it might be acceptable to them, is clearly key. By a similar strategy, we're starting to offer testing and treatment in emergency departments. It's an opt-out basis throughout London. We test for HIV, hepatitis B, and hepatitis C. And you can see here results from Barts in East London. And over the last few years, while we've been running the program, we're seeing fewer and fewer RNA positive patients. Again, an indication that perhaps we're starting to get closer to that elusive elimination target. I've been optimistic in saying that we can, with diverse access, get people into treatment, but I've also been realistic and pointed out that there will always be people who don't get access to treatment. And I think that it's important that we manage our expectations and the expectations of our political masters. We're nowhere near eliminating hepatitis C in England at the moment, but despite that, we've seen this massive reduction in deaths from hepatitis C, this massive reduction in liver cancers. So even without eliminating, we can have a very significant impact on quality and quantity of life. And this is the chart that I'm perhaps most proud of. It's an analysis by Beatrice Evgenia, our data analyst at NHS England, looking at treatments in London over a long period of time and measuring that by deprivation index. And what you can see is that in London, the vast majority of the treatments for hepatitis C have been to the most deprived members of the community. And what we're doing with hepatitis C treatment is much, much more than just changing a PCR positive to a PCR negative. We're getting to people who are disengaged, the most disadvantaged members of our communities, and we're bringing them into treatment pathways, we're bringing them into services, and I believe we're doing an enormous amount of good by engaging with the most disengaged in our societies. The challenge, of course, for elimination is how do we measure elimination in people we can't see? Modelling studies, these are fabulous modelling studies that, again, Pantelis suggested earlier on, show that we can measure by models improvements, but we're probably going to need direct measurements. We're probably going to need to go out there and directly measure people in line with the WHO guidance, and that's going to be very difficult to do. For those of you who are daunted by the idea of testing and retesting your patients to prove you've reached elimination, can I just remind you that Egypt, yes, Egypt, not a country well known for its high quality healthcare, but Egypt has already done it. And in England, we're just starting a program of testing 10,000 people, and we will retest them in 12 months' time, hopefully to show that all these interventions have led to a reduction in incidence of hepatitis C. As my colleagues in the audience who are involved in the project will tell you, it's jolly hard work. So to summarise, ladies and gentlemen, I think the population we need to find and treat for hepatitis C is increasingly inaccessible. We have made extraordinary strides in the last few years, getting it accepted that people who use drugs are appropriate for treatment and avoiding the stigma that has so long blighted this poor community. We know that diverse testing and treatment options with peers are going to be the key to success, and we know that we're going to have to measure this directly. But I think we need to remember that we are never going to be able to offer and treat every single person with hepatitis C. We will have to accept that there will be a cohort who won't get access to care. And the question is whether we're going to need something extra, perhaps a vaccine, perhaps a depot preparation, in order to finally eliminate hepatitis C. But I don't want to leave on a negative note, because I do think if you look back to where we were a few years ago, everyone in this room will agree that by not giving up, by refusing to accept that people who inject drugs are not candidates for therapy, we have changed the mould, we have changed the paradigm, and I do believe that we can eliminate hepatitis C in people who inject drugs, but I think it's going to be a lot tougher than perhaps we first thought. And on that, I thank you very much for your attention and thank you for the invitation.
Now, the title of the next presentation is Peer-Delivered Interventions Models, presented by Brian Moore from the UK, and also there will be a brief introduction by Wes Steele. I would like to welcome them to the podium, and I would like to ask them to introduce themselves.
Thank you very much. Yeah, my name is Wes Steele. I love all things that reduce harm and challenge stigma. I do apologise for muscling in a wee bit on this session, but I wanted to lay a bit of the groundwork and just give a bit of background before I hand over to Brian, who's actually delivering some of this intervention on the ground. So I still often get asked why a peer supply for naloxone. So this is a naloxone intervention. This is peer-to-peer work happening across Scotland, building on SDF and NHS Greater Glasgow and Clyde's early supply model of 2017. And I think the answer to the question really should be quite plain and simple, and I like to follow on from the previous speaker just talking about peers have got privileged access. People with lived and living experience of substance use will reach parts of a community that no other intervention ever will. I firmly believe that, and I kind of stand by that. They've got an increased reach, and they've often got instant credibility within, amongst the community of other people that are using substances. People very often don't want to approach conventional services. We know, unfortunately, in Scotland, only just over a third of people with problematic substance use are even known to a support service. So if naloxone provision conventionally is only going out from those support services, you're already missing half of the population that are at risk. Crucially, this project is paying peers. We're offering peers sessional payments, 40 hours per week across 9 geographical areas in each of those areas. I believe that's the first time that's really been done and kind of embedded into the project. Also, the prisons work. To my understanding, the first time ever, a resident in a prison can train and supply a prescription-only medicine to another resident in prison on the hall, effectively in cell the day before liberation. I know people do routinely get offered naloxone at point of release, often at reception. Often these kits don't get put into the property. Often people don't want to disclose to a member of staff or an officer that they're using substances, or they deem themselves at risk, so they'll decline a kit on leaving prison. And we've seen a much bigger uptake from that peer-to-peer supply model in the prisons. The other interesting area that I'm privileged to be involved in is just the creation of a national network. So bringing together these projects quarterly for online meetings, offering information and training sessions, area updates, sharing learning, and offering support to unfunded projects. So any projects that aren't funded through the Drug Death Task Force and our work directly, we try and link them into those, into these networks as well, and offer any support that we can. So that's just a wee bit of background from myself. I hope that just sets the scene a wee bit, and I'm going to pass over to a real expert, Brian, who has very kindly come along today to share his experience. Despite trains being cancelled, he has still made it and come through to speak to us. So I'll hand over to Brian. Thank you.
Thank you. It's good to be here. Good to get my voice out. This is just a wee bit about myself, what I've came through personally. Just a wee little about me. I'm 38-year-old, born in Glasgow. I struggled with heroin addiction for grown 20 years. I live with my partner and my children. I don't know how she put up with me, but she did for all these years. I was on a methadone script for the whole time. Couldn't find a way out. Found a way out in March when I got offered a place in rehab. That was first I'd ever heard anything like that, people helping me. So the SDF got involved with me and asked me did I want a job. And I applied for it because I didn't think it would. Not had a job, to be honest. So I said, I got the job, and I was like, I need to go into rehab, so I'm going to lose my job. And they said, no, we'll hold it for you. So they kept the place for me. And I'd done a bit of training before I went in there. And as I left rehab, came off the methadone, I left rehab in June. I've not looked back since. This is the longest I've been clean and stable in my life. I'm a 38-year-old. This is just a wee photos of what I've done I work with We Are With You in partnership with SDF. We trained Women's Aid using naloxone, Nixoid. This is just a wee picture of us out doing Overdose Awareness Week. This is the sort of stuff we do. We go out with a van, we do reaching out, we do the safer card, BBV testing, anything that needs done to help people do it. Train you in Nixoid, naloxone. Just another one of me and my workers. That's a picture of the BBV van. We turn up, and as Wes was letting on, people turn up at the van and they see people that are the active users or being addiction, they don't want to engage. They engage more with me because I know what they're going through, I know what it's like. So I get a lot of people in the van getting them tested because through my lived experience alone. And we do this day in, day out. And as I said, this is the only job I've had. Why I do this is, I do this because I'm passionate. I'm passionate about saving lives. I've lost so many people through heroin. It's unbearable thinking about it. But I know I'm out there making a difference. We're giving out, I've gave out over 90 NIXOID in August, 150 kits supplied in September. And a lot of them are, majority of them are active users, but a lot of them are people that are seeing it in the community. That you maybe don't think you're connected, but we all see it in everyday life. And it's good to have it, just in case you come across outside chemists, outside shops. We all pass people every day. And that's where the stigma comes in. As soon as you see somebody on drugs, you're like, oh, that's it, just leave them. But it's a life. You're walking away with your life. So that's why it matters to me. And why it matters even more is I get paid for this. This is the first proper job I've actually had. I've had jobs, but no, I struggled to fill in timesheets. I've got an iPad for my work. Never had an iPad in my life. I need to do my hours. And it's tough, struggle, but it's a good struggle. I've never struggled so much like that in my life to fill in timesheets. And I get paid for doing this, and I'm passionate about doing what I do here. I know I'm out there saving lives, and that's all that matters to me. I love making a difference in and around my community, instead of robbing off them, stealing off everybody. As I've said, this is my first proper job. I've got a lot of pride in doing what I do. The fact that I'm not robbing my partner out of sleep, taking money off my veins. This is your Fife outreach. This is exactly what we do. As I said, I trained 35 women age workers. They didn't see the point in it, to be honest, but it's to understand. See, when you go to speak to them, they've all got people they know, cousins, relatives that are in addiction. Everybody knows somebody that's in addiction. Maybe you don't like to know it. We also do a lot of I do shadowing or training in the air tool, BBV testing, and that goes hand in foot when you're getting out people and stuff to inject with. I find that I'm the best person to speak to them. They get me more than anybody else because they know, majority of the people I know, to be honest, I know them all, I've been around them all my life. So they feel I'm not lying to them. And that's the best case scenario. They know I'm going to tell them the truth. And that's the way I get around everything. I'll just tell them, I'll not lie to them. You know what I mean? And I'll just tell them the truth. But what I find is when they're saying the Hep C, you used to get the interferon jag. And that used to be in a lot of pain with it. And like my boss was explaining to somebody, it's not the jag anymore, right? But that person said she's a liar. But see, when I said to him it's not a jag anymore, it's only tablets, he believed me. And it's crazy, but that's the stuff that I get every day. Every day I'm out and about, putting boots on ground. I do whatever I can to help. And plus, I get paid for it, and this is the main thing. I get to contribute to my family, paying bills, food. Never done that before, and it gives me a lot of pride and passion what I do here. We supplied 11 businesses with naloxone and NIXOID premises in case of emergencies. A lot of these people are in active addiction, but they see it coming through their door. And this is the sort of stuff that we're dealing with. And I just want to say a big thank you to this for letting me come and speak here, because this is the sort of stuff that I'm passionate about, and I love this training, and I love seeing the way we're going forward. And it's just it's nice to see people here that are actually showing interest and want to see what you're doing. And I'm 10 minutes short. I only had a 10-minute slot and everything we done, but I'm really glad to be here, and thank you for letting me speak here. Thank you.
Thank you so much for your contribution, and please have a seat. Now, we have ample time for questions and discussions, so feel free to step up to the microphones and ask questions.
Or through the app.
Maybe I can start up. I would like to ask Graham Foster, thank you for your presentation. You mentioned that there was a problem with people not showing interest in receiving treatment for hepatitis C. What's your experience in the UK? Do you have any number or proportion how widespread this problem is?
Thanks very much. I think it is something that we probably underestimated. If you look at the drug services in England, where we've been really very progressively offering testing and treatment now, in every service there's a handful, a few percent, who have disinclined and disengaged and decided they don't want to take treatment. And of course, people are perfectly entitled to tell you they don't want to take tablets if that's what they wish. And what we haven't done, I think, is systematically start to examine that. We've been focusing our attention on reducing the barriers to those who want treatment to get access to treatment, and I think we've perhaps rather ignored that little subset. I was interested looking through at all of the presentations this morning. I thought there was a fabulous demonstration of outreach in Portugal, but just the numbers there, out of the 43 hepatitis C infected patients, 30 of them had started treatment. So that means to me that probably 30% of patients in an outreach program with point-of-care testing, instant access to tablets, are not taking up the offer of medication. So I think somewhere between 10 and 30% of people are reluctant to engage in treatment, and I think that's where we need to be focusing our efforts. Why are people, now that we've made it so simple, why are people still not taking up the offer of treatment, and what can we do? And I'd like to ask our peer representatives, I thought that was a fabulous talk, what are their thoughts and their impressions about people who haven't engaged? Why are people not coming forward?
Okay, thank you.
Yes, we have a question.
Hi, Sharon Hutchinson from Glasgow, and had a question as well for Graham, and thanks Graham for joining us. So it's a shame that you couldn't make it to Glasgow, but great that you could still present. My question was in relation to there's been progress on reducing the number of Hep C related deaths in England by quite a margin, but still quite a way to go. And yeah, I think we need to be really ambitious in preventing a hepatitis C death. And you know, I'm just wondering about those people that are still dying from a hepatitis C death. Do we understand what's been their path? Are these the individuals that you're talking about that are the smaller minority that are just not engaged? Is there more to learn there? In some ways, I'm quite surprised that you haven't had a greater impact in terms of reducing those Hep C related deaths. It may be down to we need to drill down into that data and to understand that better. But I just wonder whether we need to focus a little bit more on these people that are presenting with severe disease, dying, and trying to understand that, and that might inform other pathways.
Sharon, thanks for the question. I think you're absolutely right. We need to understand better why we're not doing quite as well as we think we should be doing. I think these late presentations, and we're seeing a fair rate of late presentations, people presenting with decompensated liver disease where treatment is probably too late to salvage the liver, and we do need to understand who they are and where they're coming from. The other thing that concerns me a little, and you probably saw on the slide, there is a little uptick in people with liver cancer. And certainly we're all seeing more and more patients with liver malignancy years after clearance of hepatitis C. I think that we have underestimated the malignant potential of this virus even after clearance. We've started in England now a program of scanning, sending out vans, offering fibroscans, easy access to ultrasound surveillance for liver cancer, and we're bolting that on to the hepatitis C program, because I think the next challenge for us is people who've cleared hepatitis C, have residual liver scarring, and remain at risk of liver cancer. I was out in Pakistan recently where we're doing a very large program of treatment. They see huge numbers of liver cancers in people they treated 5 to 10 years ago. They of course have genotype 3, which is a little more oncogenic, but I am a little bit concerned that we're leaving behind a residuum of patients with advanced fibrosis and a pre-malignant tendency. And I think we need to make sure that we educate our politicians and our paymasters to expect an increase in liver cancer, and we need to get more aggressive in offering patients follow-up and scanning. Because I do think you're right that we need to understand this a little bit more. I think complacent's the wrong word, because I don't think any of us have ever been complacent, but we've perhaps been focused on getting treatment out into the community, and I think we've done that very successfully. But that's not the end of the game, I'm afraid. I think there are more challenges to come.
We have a question from Brendan, and that's for Sonia Silton. And the question sounds like this: the 10% missed SVR with lower level of detection of 1,000 IU per ml, is that based on blood taken at 12 weeks, or is it indefinite? Would you pick up more if you had repeat tests at 24 and 48 weeks, for example?
Thank you for the question. So the multi-country data set that this was pulled from was like real-world data and a few pharmaceutical studies. So in the pharmaceutical studies, definitely it was at exactly 12 weeks, right? Because that was a very regimented system. In the real-world data, there was a bit of a window around the 12-week period, so it could have been more. But we did not look at any later stage, so like 24 or 48 weeks. And I think it's just also important to consider that in a lot of real-world data situations, there is difficulty with getting people back for SVR. So if you're even going to do an SVR in the first place is a tricky thing. But you can also refer to the paper where we describe the methods exactly about each of the data sets and what the parameters are around that.
Yes.
Hello. I don't like public speaking. I've drank a lot of coffee. I don't know how this is going to go. But I just thought I'd push myself. I really do feel massive. I thought I'd just push myself, Brian, because for you to stand up there today and share what you shared, it was really moving. You know, early days of recovery and everything you've been through. And for me, it really just stood out. And for you to take that risk, I thought I'd stand up here and take a bit of a risk, because I really do not like public speaking. So just to acknowledge you, and I think just to try and push for more peer support. I've worked in services for many years, and we do need the data, we need the academic, we need the clever people, we need the, you know, all that stuff, but we need people that are passionate. We need people that are going to go beyond them, you know, people that can really reach into communities. And for me, just listening to you, it's got me up here, you know, and as you were saying, if people are going to engage with people that have been through it, then that's what you need to do more, isn't it? You know, it's taking that out to communities, and you'll reach those people. Is it the docs that Professor Graham was talking about, the God only knows? You know, the God only knows are those people that might never come to services, but the power of peer-to-peer, you know, you can't beat it, you know. I'm going to stop now, but just honestly, well done, Brian, and all the best, okay?
Brian, can you tell us more about this? I understood 100 tests that were run in September. Is that right? More than 100 tests?
No, 100, sorry, 2 seconds.
So that was on the van or?
No, that was 150 kits in the Oxoid and Nixoid handed out in September. Tests in van were averaging a couple every time the van's out. So we get for instance, we try and go around different places all the time, high-risk areas, local to me, we turn up, we give them advice, and it's like, we offer them incentives and all, we give them a £20 voucher so they can go and get food, gas, electricity, shopping, but it's just to get the people in the door, and we find that it's helping, especially nowadays. People are in active addiction, they struggle with buying food and shop and that anyway. They can't go any cash, this has to be spent in shop. So they need to spend it on shopping, they need to spend it on gas, electricity, so it's giving them incentive to come in and actually, we know that they're actually going to eat that day. People sometimes have the for a while, eating isn't the top of the mind when you're active using it, use drugs all the time. So plus we're finding majority of people we're testing are come back with Hep C, and so we are out there and they're getting the tablets and they're getting the help, and we provide a lot more than just help with that. We'll help them with contacting housing and addiction services. We'll do a lot for them. It's not just we'll put them out the door, we will help them. And they need help with, guide them in the right places, and yeah, we just do what we can. We don't just test them and put them out the door. We test them and we look after them, we follow up on them, we'll help them if they're needing clean kits, if they burn, if they use foil, we give them foil. If they use needles, we'll make sure they've got clean stuff so they're no sharing needles with people. We do a lot of aftercare. Yeah, that's it.
Thank you.
Any other questions?
I was just going to say,
Microphone.
Yeah, just really good speaking. I really loved all the presentations, really interesting, and Brian, really inspiring listening to you. I was going to ask if there's any sort of, you kind of touched on it already, but any sort of tips and advice that you give to services and providers and frontline staff to help with what Graham was describing there as the service users that may not necessarily be prioritising getting a test or health. Is there anything we could be doing to help service users prioritise the health and get tested? Any tips?
Can you repeat briefly the question? It was difficult to
Sorry.
understand.
It was to say, is there any tips, advice, guidance that you can give from a service user perspective on what services can be doing to help service users to access healthcare, so to get tested?
I'll jump in on that super quickly if I may. I think relationships are key. I think a lot of people that walk through a door of any service seeking support don't necessarily want to sit down and talk about a drug diary. They don't necessarily want to sit down and do a BBV test. They just want to sit down on a cup of tea and a chat with someone first. And I think as soon as you try and come alongside somebody, in my opinion, any form of healthy relationship is harm reduction in and of itself. Normally people's health will start to improve slightly because they've got someone that actually cares about them and is asking after them, and you can then build on that to look at the more practical or physical health needs or the specific mental health needs that might be there. I think the relationship is way underplayed in all our services, if I'm perfectly honest. I think it's always outcome focused, and I struggle to see how you can be outcome focused and person-centred at the same time. I don't think you can. I think you need to be person-centred before, and the outcomes will kind of come later, and they often will take care of themselves if you've got a kind of nurturing relationship at the front, but that's just my tuppence there.
And see, in my opinion, sitting down with somebody with a cup of coffee, you learn more about them than you do reading off a bit of paper, asking them questions. So if you just sit, and people are in addiction, they're not used to getting treated properly. So you sitting down talking to them, it actually makes them feel valuable, and you talk away to somebody, you learn a lot more for that than you do answering questions off a bit of paper.
Is there any further question?
Hi, yes, I have one question, if you don't mind. So I just wrote it down, so please don't mind me while reading it. Thank you, speakers, for your informative presentation. Dr. Foster, you've raised an important question about why participants still refuse treatments We can think of a variety of reasons, such as lack of trust in clinical care. We can also consider that people have individual struggles that prevent them from getting treated. Mr. Moore, thank you for sharing your story, and we all here can appreciate your courage and work. I wanted to ask you, that from your own experience, could you share your thoughts on the kind of thoughts other folks, vulnerable folks have that may have had or still have prevented them from getting the treatment despite there being available support out there?
Just anything that's put people off getting support before, so like anything that might have put you off accessing help.
Yeah, well, like for instance, putting people off, females, I've got kids, social work. As soon as you mention you take drugs to an addiction worker or something like that, you've got kids, then women are good at hiding stuff, and they'll lie to you when it comes to the kids. They'll not tell you the truth, because they believe, and addiction services as well, they'll phone the social work that believe that you're using with your kids. So it's just trying to get around that stigma, letting these services know, helping people without telling the authorities. Somebody's asking for help, you tell authorities and they get the reins took off them, they're not going to help themselves, they're going to make things worse. So it's just trying to find the wee in between, where you can still make sure that the reins are safe, but you're not getting the reins took into care.
Can I jump in on that super quickly as well, please, if that's right? I think in a nutshell, stigma, by and large, stigma can often be very subtle. It's not always as open as kind of, really stigmatizing language and things like that. And I just think the fear of judgment, I know for myself in my own kind of personal history, fear of being judged as soon as you walk through the door of a service, and often that would play out. So I think people don't kind of make it up. They're going off evidence. I think services are changing and service delivery has improved a long way. It takes a long time for good news to travel amongst the community of people who use drugs. Bad news travels really, really quickly. I've tried to support people to certain services. They're going off how the service used to work 30 years ago, but they're going to cling to that. Like, that's fact. And it's trying to kind of undo that and then give people newer evidence to kind of go off. But yeah, I think stigma plays a massive part.
Lots of questions for Brian. There's one from Julie. Could you ask Brian how, when testing on mobile van, how they get the people to come back? Do they have any issues with finding people again to give the results? Brian.
We do have issues. The issues that we get with people not coming back is the fact that they've not got phones or anything. But see, often people cups of coffee and lend an ear. Majority of people come back, and the team I work with, we're all ex-users. So I've got two lasses and another guy I work with. So we're there and we always support them. And they find out, they come to us just to talk about normal stuff. And we find that a lot, they come back. But we'll tell them we're going to be here this day, that day, and we'll make a point of coming back that day to make sure that they come back. So majority of the time we get the people back. If no, we'll hunt them down. We'll find them eventually. We find them, but a lot of people have not got phones and that, and that's the problem. But I've no majority of people in that where I'm from and that, so I know majority where they get people and that is. So most of the time we get them, and if we don't get them, the reason is we don't get them is they're scared of the results. That's the problem.
I had a question for Sunela. In her very nice presentation, you were showing us an advantage of the point of care approach towards DBS, in terms of outcomes. And as we know, eventually point of care approach does not fit all, right? The settings or the conditions of certain regions. And that's why I would like to know a bit more about the DBS protocols, how were they run, if there was like a standard protocol for all this DBS, or if they were locally adapted with the protocols they have already in place and the machines that will make them even more cost effective.
Yeah, that's an excellent question. I think you might be referring to the Georgia example, is that right? So just a point of clarification, in Georgia it was looking at the point of care molecular compared to a venous blood sample. So that was spun, so that was plasma. But the point about DBS and the protocol used is an important one, because when we talk about the DBS work that's done in England and in Australia and everything, those are all using off-label protocols. So those are lab-specific design protocols of how to run the RNA. This is okay, it works, but there's not a standardization because each lab is deciding how they're going to do the extraction process. So recently we worked with a number of research institutions in a number of countries to look at manufacturer protocols. So these were the protocols that Abbott and Roche and Hologic had put together to say, like, this is the way that we think you should do it, this will get the best outcomes. And we looked at real world use of that in several countries. I'm not remembering all of them: Cameroon, Georgia, and like 3 more, sorry that I forget. But we wanted to understand what happens when you leave the DBS sample in a bag for 3 weeks because the Riders for Health or whatever your transport network is not going to come pick it up. And then also what happens in the lab. DBS, I don't want to get too boring, but it's like not fun for a lab tech to do DBS because you've got to like hole punch out each one. You hurt your hand a lot after doing it. There's not automatic automatic punches in a lot of labs. You get a lot of cross-contamination, right? Because you're supposed to sterilize these ones. So we've looked at the performance of that. I know that Abbott is submitting a change notification to WHO PQ on that, and we are hoping that Roche and Hologic may do similar. So the paper should be forthcoming. We're just a little bit, we got swamped with COVID stuff, so but hopefully we'll publish that paper soon.
Thank you. So if there's no further question.
Well, there's one comment.
Oh, there's one more.
There's one
Great.
comment from Sean. Could you let Brian know if he wants to change employer, we would love to have him work for us.
No. No. Someone's trying to headhunt me.
Okay.
So that's not really a question, it's an invitation. So it's been really amazing discussion, interaction, and we were reviewing new testing approaches as well as treatment scale-up and all the different models of care in UK and abroad. And then we came into the real world with Brian and Weiss and the challenges which are there. And there's still a lot of challenges. As we saw, we must also start thinking about what we do with the follow-up of the patients we already treated, that they don't end up anyway with consequences of an unseen disease that stays. So I thank everybody, especially our amazing speakers, and of course, Professor Olafsson also that has been sharing this session. And we wish you to continue the poster viewing and later on the gathering of the conference. Thank you all.